The next disease we'll discuss is gout, a relatively common disease that is important to know as well. You'll see it on step 1 and on the wards and need to differentiate this joint pain from OA, RA, or other joint pathology. Biochemically, this disease is characterized by precipitation of monosodium urate crystals into joints due to high serum uric acid levels. Now, what's the gout catchphrase? Look out for negatively birefringent crystals, or yellow crystals in parallel light. You can use the double L mnemonic highlighted here to help you remember that the chronic treatment, too, is alpurinol. There are a lot of causes of gout, theoretically due to two major problems. Uric acid can either be overproduced or underexcreted, which can cause high serum levels, thereby leading to a higher likelihood of crystal deposition. Of the two, underexcretion represents about 90% of cases. Commonly, your patient will have just started on a diuretic, such as furosemide, so look out for the CHF patient on diuretics with acute knee pain and a question stem. Do you recall from biochemistry how Lesch-Nyhan syndrome works? HGPRT deficiency causes a buildup of uric acid. Patients get, you guessed it, horrible gout. PRPP excess also occurs in patients who have a mutant PRPP synthetase, causing it to be insensitive to feedback inhibition. So what builds up? Purine nucleotides and uric acid. What about von Gierke disease? Here you have glucose 6-phosphatase deficiency. How does it result in hyperuricemia? Increased levels of G6P is metabolized by the pentose phosphate pathway to generate uric acid. What other metabolite is overproduced in von Gierke disease? Lactic acid, which competes in the renal tubules with uric acid for excretion. Thus, for these inborn errors of metabolism, patients have both increased production and decreased excretion of uric acid. Certain medications and increased cell turnover can also result in hyperuricemia and gout. The case vignettes are always rather similar, usually a male patient with some external insult leading to a gouty flare, likely in a single joint, most commonly the MTP of the great toe. A classic example is a patient who is treated with chemotherapeutic drugs for leukemia who turns over cells very quickly due to rapid cell death from the chemotherapy, leading to a huge overproduction of uric acid. This precipitates a gouty attack, thereby causing a man being treated with the standard therapy for his cancer presenting to your clinic with intense, extreme joint pain. Now, how do oncologists anticipate this problem? Premedicating all patients with large tumor burdens with allopurinol, a blocker of acid production, to prevent it from being created. This allows serum uric acid levels to stay low. We'll go over the mechanism of the allopurinol later in the pharmacology section. So how does gout commonly present? The symptoms of gout classically consist of an asymmetric joint distribution, and often a red, swollen, painful joint, most commonly the MTB of the big toe, as pictured here as well. With long-standing gout, the crystals can precipitate into deposits called tophi or tophaceous gout. These tophi can be anywhere, but classically appear on the external ear, olecranon bursa, or Achilles tendon. Now, why do crystals form here? Well, basic chemistry. These are the areas just a few degrees cooler, and so crystals more readily precipitate. The tophi themselves don't cause problems, it's truly just the acute attacks that are painful, and they don't occur at the sites of tophi necessarily. What precipitates an attack? Large meals or by drinking alcohol, both of which allow for uric acid levels to increase. With alcoholism, as with HIV and certain other important chronic diseases, it's important to build a list of common complications and diseases that often present with them so that you can use it as a shortcut when you see them in a clinical vignette. This is a great one to add to the alcoholism folder in your brain, along with thiamine, B12 and folate deficiency, and DTs, which you'll remember from the biochem chapter. Why does a long night of drinking result in a gouty attack? Alcohol metabolites compete with uric acid in the kidney for excretion. The treatments for this disease are varied and usually determined by the clinical presentation. What can we do for patients acutely? The goal here is not to try and acutely drop the serum uric acid level. The goal is to control their pain and inflammation. What drugs work for this? Think NSAIDs, steroids, and sometimes colchicine. Once the acute flare has resolved, the goal is to try to reduce the serum uric acid level and keep them low so the patients are less predisposed to acute attacks. This is accomplished mainly by allopurinol, which inhibits the formation of uric acid, and less commonly probenecid, which causes the kidneys to excrete more uric acid. Flash quiz. What drug can you give to prevent a gouty attack due to tumor lysis syndrome, or fast cell turnover after chemo? Right, allopurinol. Pseudogout is just like gout, but a different type of crystal. We aren't dealing with uric acid anymore, but calcium pyrophosphate crystals. How can you distinguish gout from pseudogout? One thing that might raise your suspicion is gouty symptoms in a large joint like the knee. Pseudogout is usually in larger joints. The definitive distinction is in the crystals. Pseudogout crystals are weakly positive birefringent, which means they are blue when parallel to the light. Additionally, because they have calcium in them, the crystals are visible in the joint space on X-ray. Just remember that P is for both pseudogout and pyrophosphate. Do you remember what disease pseudogout can be associated with? Hemochromatosis. Patients are usually older and can be male or female. You should look out for patients with a history of hemochromatosis, hypoparathyroidism, or osteoarthritis in the question stem. You can treat an acute attack with NSAIDs or glucocorticoids. Patients also benefit from colchicine for prophylaxis. Flash quiz. What shape are pseudogout crystals? Rhomboid in shape. Patients with autoimmune diseases will often have multiple autoimmune diseases at the same time, and one of the very classic pairings in patients with rheumatoid arthritis is Sjogren's syndrome. How will a patient with Sjogren's present? Classically, there is a triad of 3 symptoms that are seen. The first is xerophthalmia, which refers to dry eyes. But patients may present saying they have the sensation of sand in their eyes, namely because they're not producing tears effectively. The second is xerostomia, which means they have the sensation of a dry mouth, which can also cause dysphagia, namely because chewed food is not being lubricated with enough saliva to make it easy to swallow. The third, arthritis. So what is the underlying mechanism of pathology here? The exocrine glands are being destroyed, especially the lacrimal and salivary glands that give rise to the 2 major symptoms. Patients with Sjogren's may also present with parotid enlargement, which occurs because it is only the submandibular and submaxillary salivary glands that stop producing saliva, while the parotids have to make up for the difference, and they compensate by enlarging. What may you see associated with the disease? B-cell lymphomas, which are more likely in patients with autoimmune diseases as a result of chronic inflammation that predisposes to dysplastic changes. Dental caries are also more likely because saliva has a number of chemicals that will aid in dental health, but without these enzymes, teeth are much more likely to have bacteria and plaque buildup. The antibodies to know for Sjogren's disease are anti-RNP, anti-SSA, or anti-Rho, and anti-SSB, or anti-La, with Rho and La being the more important ones to remember. SS in the name stands for Sjogren's syndrome. So how will this patient present? Well, it'll most likely be a woman aged 40 to 60 with a history of rheumatoid arthritis. Flash quiz. What disease is most likely to cause a patient to complain of sand in my eyes? Sjogren's syndrome. Look for a dry mouth as well.